Good afternoon. Welcome to the Congressional briefing entitled, "Their Lives Depend on Us, Rising to the Challenge of Providing High Quality, Evidence-Based Reproductive Health Care for Women with Sickle Cell Disease." My name is Dr. Chancellor Donald. I serve as the chair of the Committee on Practice for the American Society of Hematology. The American Society of Hematology is pleased to co-sponsor this briefing with a few noble organizations, including the American College of Obstetricians and Gynecologists, the Association of Maternal and Child Health Programs, the Foundation for Women and Girls with Blood Disorders, the Sickle Cell Disease Association of America, the Sickle Cell Reproductive Health Education Directive. On behalf of the co-sponsoring organizations, I would like to thank everyone for joining us today. We appreciate all of the congressional interest in sickle cell disease with the aim of improving the lives of our citizens living with sickle cell disease. I would like to take a moment to especially thank our congressional sickle cell disease champions, Senators Tim Scott and Cory Booker, as well as Representatives Danny Davis and Michael Burgess, for their continued dedication to raising awareness for sickle cell disease on Capitol Hill and their commitment to improving the lives of individuals with sickle cell disease. It is a pleasure to work with these leaders, and we hope others will join us in these important efforts. Regarding an overview of this brief but informative program, we will first, of course, talk about and give a background of an overview of sickle cell disease. We will have the impact of sickle cell disease on reproductive health and maternal health by Dr. Lydia Pecker of Johns Hopkins University. And then we'll have a mother story by Ms. Ifa Ahmed, a sickle cell disease advocate and champion. And then I will follow with a presentation of potential policy strategies. And of course, we will have a question and answer session. Regarding an overview of sickle cell disease is an inherited blood disorder that affects an estimated 100,000 Americans that are primarily African American and Hispanics. It impacts millions worldwide as well. Approximately 300,000 births per year are to persons with this condition. Individuals with the disease produce abnormal hemoglobin, which causes severe pain and can lead to strokes. The highly morbid condition of acute chest syndrome could be an occurrence, as well as organ damage, and in some cases, premature death. Common complications experienced by persons living with this disease include severe pain, organ damage, stroke, life-threatening infection, and clinical sequelae that ultimately lead to death. It is a disease that illustrates critical healthcare disparities and inequities. And there are even further challenges. Though new approaches to managing sickle cell disease have led to improvements in the treatment and supportive care of this condition, many people living with the disease are unable to access quality care and are limited by a lack of effective treatment options. Barriers to receiving quality, comprehensive care for sickle cell disease are significant, and they result in healthcare disparities and inequities. COVID-19 has further disrupted care and increased these challenges, and unfortunately, increased patient morbidity and mortality. With that, I would now like to introduce Dr. Lydia Pecker, an expert in the field, to speak on the challenges faced by some of our patients living with this condition. Again, Dr. Pecker is of Johns Hopkins University, and we are pleased to have her on this program. Dr. Pecker.
Thank you, Dr. Donald, for that nice introduction. It's a pleasure to speak with you about reproductive health care for girls and women with sickle cell disease, and to highlight why, in that context, comprehensive care is absolutely required. Next slide, please. As Dr. Donald just presented, sickle cell disease is a genetic disorder. It's autosomal recessive. And although I'm going to focus on girls and women today, we always remember that men and women get this disorder in equal numbers, and that it is not actually a disease of Black people. It is a disease that affects people of African descent because of the evolutionary pressures of malaria and the transatlantic slave trade, and also contemporary immigration and migration patterns in the United States context. If we lived in Saudi Arabia, sickle cell disease would have a very different face, though many of the same disease complications. Next slide, please. I'd like to start and really animate my discussion of reproductive healthcare today with the patient's story. Ms. Smith is a 28-year-old patient of mine who has sickle cell anemia, which is a severe form of the disease, and was a first-generation immigrant from Jamaica. I met her when she came to me for preconception counseling and treatment recommendations during her pregnancy. Next slide. My patient's parents moved from Jamaica when she and her siblings were born. And as you can see here, this really shows the global distribution of children born with sickle cell disease, highlighting that in the historic malaria belt, most patients with this disease are born. And again, as the migratory pressures of the disease of humanity have moved the disease around the world, including to the United States. As you may know, adults with sickle cell disease are surviving into their 40s and 50s, and actually greater than 60% of individuals with sickle cell disease are adults who lack high quality care in many cases. And I would like to suggest to you today that that high quality care must include reproductive care, and will continue to follow my patient to illustrate why. So Ms. Smith was referred to me because although she does have a hematologist, her own hematologist did not have specialty expertise in sickle cell disease and was particularly concerned about managing sickle cell disease in pregnancy. And in her own healthcare system, there were no maternal fetal medicine experts, who are sometimes called high-risk obstetricians with sickle cell disease expertise. And so she came to us at Johns Hopkins for advice. Next slide, please. Sickle cell disease, as Dr. Donald described, is a systemic disease. Blood goes everywhere, and so does sickle cell disease. It can affect the blood, the brain, the heart, the lungs, the kidneys. The major joints of the body are affected. The penis is affected. The ovaries are affected. This is a really diffusely affecting the body disease. My own patient had complications that included pain that was intermittent and also associated with menstruation. She had degenerative hip disease. And although she worked on her feet every day, had very severe pain in her hips. And twice she had been affected by a life-threatening lung disease of sickle cell disease called acute chest syndrome. Next slide, please. She was diagnosed in the 1990s on newborn screening and had a younger brother who was cured of sickle cell disease with a bone marrow transplant from an unaffected sibling. Next slide, please. Having sickle cell anemia in a matched sibling donor, which is true for about 10% of children affected by sickle cell anemia, is an indication for curative transplant therapy. And transplant is a risk for infertility. And this late effect is a barrier to cure. We have fertility preservation strategies for both girls and women with sickle cell disease, but they are not yet covered by major public insurances, and therefore do not reach most individuals with sickle cell disease. And this is one site of the need for reproductive health care, starting really with girls and their families before puberty. Next slide, please. Children with sickle cell disease need comprehensive reproductive care, and that may seem premature, but hopefully this idea of being exposed to gonadotoxic chemotherapy makes it clear that there are complex decisions that affect fertility, and that families and children, and as they become adolescents, need anticipatory guidance and information about puberty, menstruation, contraception, fertility, and eventually pregnancy. All of these things are touched by sickle cell disease, and all of them require expertise to inform appropriate care. My patient, we continue her through her young adulthood. She did get her period at about age 17, and she had menstruation-associated sickle cell pain associated with daily back pain. And so she started on our best treatment for sickle cell anemia, which is hydroxyurea, and she was also put on oral contraceptive pills to help control the pain she experienced with her periods and also to prevent pregnancy. Next slide, please. Menstruation causes debilitating pain in as many as 30% of women with sickle cell disease. It's an underappreciated cause of pain in girls and women with this disease, and it leads to missed school, missed work, and hospitalization for treatment with IV opioids. And studies that address whether contraception or sickle cell treatment modify this severe pain are needed and have not yet been performed. And the other problem with contraception, in addition to whether it might help with sickle cell disease pain, is that many forms of contraception contain estrogen, and estrogens increase the already high blood clot risk in women with sickle cell disease. And so in the absence of rigorous data, we are confronted by making difficult decisions about what kinds of hormonal contraception to offer women with sickle cell disease because they may be at risk for blood clots with some of the more common forms of contraception. Some reasons that girls and women need comprehensive care to manage their sickle cell disease that includes reproductive health care is that how disease and treatment affect menstruation, menses-related pain, pregnancy, and menopause needs to be addressed. We need more universal awareness across multiple specialties about the risk of thrombosis of blood clots in women who are treated with estrogen. And this comprehensive care really is essentially multidisciplinary. It requires hematologists, it requires internal medicine, pediatric specialists, reproductive endocrinologists, high-risk obstetrics, and gynecology. It requires transfusion medicine experts who know about blood banking and how to safely give our patients blood transfusions, genetic counselors who can communicate appropriately with families to articulate genetic risk and the heritability of sickle cell disease, not just to patients, but also their families. It also requires community health workers because these are essential team members for us as we try to help our patients reach the complex and varied care that they need to maintain their health. Next slide, please. So Ms. Smith got married and she wanted to start a family. And when I met her, she was clear that her husband does not have trait. She knew that because her husband had gotten appropriate testing with the right test that was correctly interpreted by an expert in interpreting that test. Many individuals with sickle cell and their families have either been given the wrong test to test for sickle cell trait or the wrong interpretation of that test. And so the expertise about understanding the heritable risk of sickle cell disease and trait really starts with interpreting these tests, and that really starts at comprehensive sickle cell centers. Next slide, please. So when I see a woman who is pursuing pregnancy, I really think broadly about the need for this comprehensive care because it is complex. Sickle cell is an inherited disease. So as I said, we need the correct partner testing and interpretation. We need clear and accurate information sharing and connection to other sickle cell care team members, preferably before pregnancy occurs because pregnancy is high risk. And once it occurs, you're kind of running to catch up. Pregnancy spans the pediatric to adult healthcare transition. At Johns Hopkins, the median age of first pregnancy in my young adult cohort is 21 years. And in many healthcare systems, though not our own, pregnant teens are abruptly transferred for adult care, jeopardizing long-standing pediatric relationships and care environments that may actually care for them best. And so pregnancy is never casual in girls or women with sickle cell disease. It is high risk for the mother and it is high risk for the fetus. And although we now have 4 FDA-approved drugs for individuals with sickle cell disease, we have none that are approved in pregnancy. Hydroxyurea, which as I mentioned is our best treatment for sickle cell disease and certainly the most studied, is a mild chemotherapeutic, and its use in women of reproductive age has long been of interest and is a subject of my own research. However, we have no definitive studies about the safety of this drug during pregnancy. Transfusion has protective effects for the mother. The protective effects for the fetus are not established. And at many centers, transfusion as a definitive treatment for women with sickle cell during pregnancy is not accepted because there are also risks associated with transfusion, which include the chance of developing an antibody, which would make it difficult to be transfused in the future. Next slide. So I did put Ms. Smith on blood transfusions because that is our practice at Johns Hopkins, and she started trying to become pregnant. She was benefited from reasonably good protection from her sickle cell disease with chronic transfusion therapy. That is, she came in monthly to the center to receive blood transfusions. And she spent 12 months trying to get pregnant and did have a miscarriage early in her first trimester of her first pregnancy. But at age 28, she finally became pregnant and was able to carry a baby to term. Next slide, please. I wanted to talk about why, although this is a happy story, once individuals with sickle cell disease are pregnant, we as their healthcare providers are exceptionally anxious. And this slide really illustrates this. I'm going to start in the middle. This is data from the National Inpatient Sample, which tells us about a proportion of patients in the United States who are hospitalized in a given time period. This is from about the last decade. And these are markers of severe maternal morbidity, and they are divided here between individuals with sickle cell disease and Black individuals. And again, in the US context, this comparison is apt because the predominant individuals with sickle cell disease are disproportionately Black in the United States. And what I hope you can see here is that for each of these measures, the severe maternal morbidity, and then each of these aspects of severe maternal morbidity, cerebrovascular events, blood clots, respiratory distress, sepsis, which is systemic infection, acute kidney failure, shock, eclampsia, and disseminated intravascular coagulation, which is a blood disease. Each of these, you can see these outlying lines. These are women with sickle cell disease. And so what this really illustrates is that the sickle cell disease itself is an intrinsic risk for adverse outcomes in pregnancy. And when we did some fancy statistics on this, what we identify is that at least 70% of severe maternal morbidity in women with sickle is attributed to sickle cell disease. And so even though we know that transformation of pregnancy outcomes for Black women is essential, even if we take this critically important step with the Momnibus and other forms of legislation and policy and practice changes, if we only make those changes, we will leave women with sickle cell disease behind. Next slide, please. So during pregnancy, I told you about all these things that could happen. What happened to Miss Smith? Well, she had monthly blood transfusions for a total of 28 months, which is a long time and very disruptive to people's lives. She saw our maternal fetal medicine experts every month during her pregnancy. She had to stay home from work 4 times with severe pain crises and took oral pain medicine, opioid pain medicine, to alleviate those painful crises. She was admitted close to her 3rd trimester with a pain crisis so severe that she required IV pain medication. Her fetus was ultimately diagnosed with intrauterine growth restriction, which is common in women with sickle cell disease. And as a consequence, she was induced at a nice pregnancy gestation of 36 weeks, which is late preterm. She had a small but healthy baby girl who does have sickle cell trait. And after she concluded breastfeeding, she resumed her hydroxyurea. Next slide, please. So one of the more remarkable aspects of this story that I need to point out to you is that she did not die. And I believe that we can attribute a fraction of this outcome to the fact that she received high quality multidisciplinary care. Mortality from pregnancy and sickle cell disease seems not to be inevitable, and that's based on emerging reports from established high-quality sickle cell centers here at Johns Hopkins, at Ohio State, and even in Canada at Toronto. We are seeing that where care is multidisciplinary and incorporates both sickle cell expertise and high-risk obstetric care, 10-year maternal mortality approaches 0. So this multidisciplinary care is really essential. And as we start to think beyond survival, which we can do once people start to survive, we need to be asking questions about what kinds of effects anemia and opioid exposure have on the children of women with sickle cell disease, to understand whether those children are at risk for neurodevelopmental outcomes of concern. And of course, that's essential as we counsel women during their pregnancies and in preconception counseling. Next slide, please. Comprehensive sickle cell disease care includes complex multidisciplinary reproductive care. And so I hope that you know and can see that funding this care facilitates high quality care and can really change reproductive health outcomes. Reproductive health care needs are normative in this population and really quite complex. And that these comprehensive care centers can coordinate and harmonize input from diverse opinions and experts from many fields. And that we need not just funding this care, which alone can help really change outcomes, but also funding to incentivize research to answer fundamental, enduring, and pressing questions about fertility, about contraception, about pregnancy pathophysiology and treatment in women and girls with sickle cell disease. Next slide. And so I will say to you, the opportunity is ours. When we think about sickle cell disease as a reproductive disease across the lifespan, there are many opportunities for intervention, for education, and for really high quality world-class care that I think we have the ability to provide in this country, and that I think we have reached the moment to really do it. I think the zeitgeist is with us. And I'll say thanks to you. I have a student who's funded by the American Society of Hematology who's been working on developing this research with me, Macy Early, and also my mentors, Dr. Smith-Whitley and Dr. Lanscron, who always are at my back blowing wind when we do these things. And I'll take any questions, and thank you for your time. And with that, I would like to introduce Ms. Ife Ahmed, who is an inspiring patient advocate and will tell her story about her own pregnancy and motherhood as an individual living with sickle cell disease. Thank you, Ms. Ahmed.
And very quickly, if there's any questions, please put them in the Q&A box, but we'll answer questions at the very end of the presentation. So save them for the end. Thank you.
Good afternoon. My name's Ife Ahmed, and I cannot see myself, so I'm hoping that you can.
Yep, we can hear you.
You can hear me.
There you go.
All right.
Hear and see.
Okay, great. Great. I would first like to say thank you for inviting me to share. And I'm sharing as an advocate and a parent, as a patient with sickle cell, and also as someone who has family members that have sickle cell disease as well, in hopes that my sharing will help others. I am, at the time of my pregnancy, I was a graduate student at Morgan State University, and I had some genetic treatment and genetic testing. And so I had been on a journey of knowing that I wanted to have children, and didn't know exactly when, but within the near future. And so had kind of started that journey. I was not taking any hydroxyurea for that reason, but I did not require monthly blood transfusions either. I have SS disease. And so one of the most important things for all people that have chronic illnesses really is how they care for themselves, but particularly for people that have SS disease or sickle cell. So I set on a path of being as holistic as possible and being as natural as possible within healthy confines of my disease and what care was available at the time. I had in advance picked a primary care physician that I'd had for years, but I had also planned and picked an OB that had experience with high-risk pregnancies, and particularly with patients that had sickle cell disease. And I was being seen at Johns Hopkins Hospital by a hematologist, Dr. Sophie Lanscron, whom I had had probably at that time about 6 or 7 years. So she was very familiar with me and I with her, which was very important. Having those providers all working together, all being a part of one hospital system was very helpful. And having them having a certain amount of expertise was also very, very helpful. My primary care physician, because my overall health was pretty good at the time, kind of took a backseat at that time, and really the OB hematologist and myself kind of drew this sense of getting me over the hump of having a healthy pregnancy. I actually found out that I was pregnant in a crisis. So I went to the hospital and found out for a crisis and found out that I was pregnant at the time. Nurse there doing her due diligence asked if I were pregnant, and I said no, and then I couldn't remember. I was like, I'm pretty sure not. And luckily, she didn't want to take the risk with the medication that she would have been giving me was not for pregnant women, and she did a test. And that's how I found out I was pregnant. That was in May, the end of May. And I delivered a baby girl in January of the next year, January 1st of 2005 at 37 weeks. And so it was a term, considered a term pregnancy. And in between May and January, I had 7 hospitalizations, was sent home on oxygen. All the hospitalizations were as a result of sickle cell crisis throughout the pregnancy. And the oxygenation, the need for oxygen toward the end of the pregnancy, around the 8th month, was due to just not being able to stat normally or have a normal oxygen level because of the pregnancy. So as children begin to grow, they really take all that they need. And so mine was literally suffocating me by taking all the oxygen. I like to tell her that from time to time, to be reminded of all the sacrifices I made for her. And so the most important thing throughout my pregnancy was, of course, having really good OB care, really good interaction with my hematologist, and the two of them really having good communication. And I found the biggest obstacle is being treated at Johns Hopkins Hospital. Is in an area of the city that experiences, particularly at that time, really lower socioeconomic status, the community around it. Its emergency room is often used as primary care physician space. And so there are lots of things that are happening in urban areas that the hospital, of course, is responding to, and that spills over into their labor and delivery area. I also found that their labor and delivery staff, at that time at least, tended to be older, white, and appeared often to be more conservative to me. And I definitely felt that there were times where I was being discriminated against because I was Black. And there are also times when I noticed the shift and this idea of being treated differently until they found out I had a husband, until my husband appeared. And then somehow things happened a lot faster. So again, some of those socioeconomic things and class things that happen in inner city hospitals. I would say overall, the experience was good. And that was largely because of the comprehensive care of the specialists. I would say that the labor and delivery experience was fair. And that's how I would describe it. I think it definitely could have been, I know that it could have been a lot better. I know that there are a lot of things that happen based on stereotypes, just simple things like people asking you, is this your first pregnancy? And you say yes, and they say no miscarriages, no abortions, as if you don't have a clue what a pregnancy is. So to be asked that repeatedly, and then the follow-up question repeatedly, I found to be very annoying. And at that time, I was a graduate student, and which means I already had a degree. And it shouldn't matter what my education level is. Women generally know when they've been pregnant before. And things like that, and my age, are you sure you're this age and this is your first pregnancy? These kinds of comments I found difficult to have to deal with each time I was in labor and delivery, when I'm trying to focus on getting rid of the pain and obviously carrying a healthy pregnancy, a healthy child. I'd say that's about it, unless folks have any questions.
We'll certainly have questions for you at the end, Ms. Ahmed. I do want to just take a moment to just especially thank you for sharing something so deeply personal and being vulnerable with this large group of people that you haven't met at this point. But I know you do it in the spirit of advancing others, and I'm happy to be a part of a program with someone like you that's willing to share that much in a setting like this. So thank you. I also would like to thank Dr. Pecker for taking the time of sharing her expertise. And we certainly look forward to answering questions for the both of you, including myself, at the end of the presentation. But at this point, we will move on and we will discuss policy strategies that could potentially be enacted. I do want to say before I go any further that all of us coming together to share this in this setting, it really benefits the patients that we hope to improve the lives of. And certainly we gain at our organization, our society, as well as the co-sponsoring organizations. We benefit from these contributions. So now speaking to you as representatives of the offices of the Congresspeople in which you work, I now want to ask you to join us in this effort to help address these issues. Today, I will highlight several specific areas where Congress can take action. An important step is to help encourage support for FY 2022 funding and medical research and public health programs. Your support will help expand important federal programs, including the support for funding for NIH to allow for additional research in sickle cell disease and reproductive health. To support federal programs already in place, we have the CDC Sickle Cell Disease Data Collection Program, and this is extremely important. This program is desperately needed to help us better understand the needs of individuals living with sickle cell disease. Information on these individuals, where they live, what insurance they use, where and how often they seek treatment, is needed in order to improve the quality of care delivered and to help lower costs associated with treating this population. Another area of support is the HRSA Sickle Cell Disease Grant Programs, which include the Sickle Cell Disease Treatment and Demonstration Project and Sickle Cell Disease Newborn Screening Program. Now, I would like to draw your attention to the important and very timely Sickle Cell Disease Medication Demonstration Bill. As background, the American Society of Hematology has had an interest in creating a demonstration project to improve the quality of care for and reduce costs associated with treating individuals with sickle cell disease for nearly a decade. Since the COVID-19 pandemic, data has revealed the disproportionate impact on the African American community, and ASH felt a renewed sense of urgency to improve access to quality outpatient and preventative care for the sickle cell community. And with this, we drafted an outline of an amendment to the bills Congress was considering to address the public health emergency. The bill was unfortunately not introduced at that time, but we have spent the past 1.5 years working with our congressional sickle cell disease champions, and we are excited that we are very close to its introduction. The bill would direct CMS to develop a demonstration project under Medicaid focused on improving comprehensive, high-quality outpatient preventative and primary care for individuals with sickle cell disease. We hope to get this bill introduced soon, and our desire is to have as many members of Congress as possible to consider co-sponsoring it. Before we get into the details of the demonstration project, I want to give a brief overview of sickle cell disease and Medicaid. As you may know, Medicaid is the primary insurer for individuals with sickle cell disease. According to data from the Centers for Medicare and Medicaid Services, approximately half of the individuals living with sickle cell disease in the United States are covered by Medicaid. The most recent data from CMS stated that in 2017, 78% of Medicaid beneficiaries with sickle cell disease had at least one emergency room visit. And that is compared to only 34% of beneficiaries without sickle cell disease. The data also stated that in 2017, 49% of Medicaid beneficiaries with sickle cell disease had at least one inpatient hospital stay, compared to only 6% for beneficiaries without sickle cell disease. This is just to show that the current model of the delivery of care for this population is costly to state Medicaid programs. And we believe that these costly services can be avoided with improved primary and preventative care. And that leads us to the demonstration. The goal of the bill is to improve access to high quality outpatient care, including clinical, mental health, ancillary, and support services for individuals with sickle cell disease who are enrolled in Medicaid, targeting young adults and pregnant women with sickle cell disease. This type of program could help so many people with sickle cell disease, and especially pointing back to Dr. Pecker's talk, it could provide the type of comprehensive reproductive care needed to help decrease the adverse pregnancy outcomes, including maternal mortality. This program would give priority to states who participate in the CDC Sickle Cell Disease Data Collection Program and states with high prevalence of citizens with sickle cell disease. Participating states will receive full federal reimbursement for services and care coordination provided during the demonstration. The services that would occur under the demonstration bill would include the creation and/or augmentation of multidisciplinary care teams that include the physicians needed to adequately treat an individual with sickle cell disease. Also, the assessment of the barriers to care experienced by patients living with sickle cell disease, taking into account social, demographic, and economic factors, as well as geography, provider shortages, and other issues contributing to health inequities. Another service would be the identification of best practices for improving health equity for individuals with sickle cell disease, and communication of these best practices to providers through the provision of education, training, and technical assistance. And lastly, expansion of the expertise of providers in the state caring for patients with sickle cell disease by disseminating clinical practice guidelines and providing education, training, and technical assistance. Regarding the overarching goals of the demonstration project, we want to, number one, ensure access to primary and preventative services, including reimbursement for care coordinators, community health workers, and other non-traditional service providers. Number two, develop individualized, comprehensive patient-centered care plans. And number three, ensure the coordination of and access to essential services. Drawing back to Dr. Pecker's as well as Ms. Ahmed's story, I'm sure you can see an organized approach to primary and preventative care for individuals with sickle cell disease, as illustrated in this demonstration project, is desperately needed to improve the health and quality of life of these citizens. Now circling back to how you can help. Again, we ask of you today to, number one, support FY 2022 funding for medical research and public health programs. And number two, consider co-sponsoring the sickle cell disease Medicaid demonstration bill. For more information on these issues, please reach out to Tracy Rhodes. She's on the staff of the American Society of Hematology, and her email is on the screen now. Thank you for your time today. We look forward to working with you. We will now open the floor for questions, but before I do, we do have representatives of the offices that have championed this effort on our call today. I first would like to mention Ms. Kim Miller-Tolbert, who works in Senator Booker's office, as well as Ms. Catherine Lentz, who is in Representative Burgess's office, and then lastly, Caleb Gilchrist with Representative Davis. I will hand it off to them to give a few words, and then we'll take questions and answers.
Hi, Kim and Caleb, I'm happy to kick it off, and unless y'all want to go first. Thank you so much, Dr. Donald and Ms. Ahmed and Dr. Pecker for joining us today for this incredibly important conversation. I'm Catherine Lenz with Congressman Michael Burgess's office, representing the 26th District of Texas, and appreciate the opportunity for this quick plug on this exciting new bill that Congressman Burgess has been working on with Congressman Davis and Senator Booker, and hopefully we'll be introducing it very soon, so keep your eyes peeled. But as Dr. Donald mentioned, this important piece of legislation would direct CMS to establish a Medicaid demonstration program for sickle cell disease in up to 10 states to improve access to comprehensive and high quality outpatient care for individuals with sickle cell disease. And I think, as we all heard today, it is so incredibly important to ensure that there is comprehensive and holistic access to care for individuals with sickle cell disease. And I think Congressman Burgess and Congressman Davis and Senator Booker all agree that this would be an effective mechanism to improve patient access to some of these more holistic and comprehensive services for primary and preventative care. And I think hopefully by allowing access to some of these services, the goal is to decrease the amount of hospital admissions and emergency room visits by those living with sickle cell disease. So we're very excited to almost be across the finish line and introducing this. And I think as some of you may know, Congressman Burgess and Congressman Davis have a long history of working together on multiple successful legislative efforts over the years to improve the lives of those living with sickle cell disease. And I know Dr. Burgess is incredibly grateful for Congressman Davis's partnership on this exciting new effort. And I just thank you for allowing me the opportunity to join you all today. I think this briefing covers two of Dr. Burgess's most important policy priorities, maternal mortality and sickle cell disease. So I'm very happy that you held this briefing, and thank you so much for allowing me to join.
Thank you so much, Don. Do we have Caleb and Kim still on the call for a few words? Okay, if they had to drop off, I would now hand it over to Foster Curry to address any questions that the attendees may have.
Great, and thanks again to our speakers for a wonderful presentation. So just to sort of kick off the question and answer section, so I'll address this to Dr. Pecker and Dr. Donald. What distinguishes good treatment of pregnant women with sickle cell disease, and what could be changed about the health system to facilitate good treatment?
I'm happy to let Dr. Pecker speak on that, unless she would like for me to go first. But given her work, her institution's work, and but if you want me to go first, I'm happy to.
You go first.
Okay, I think not to be too wordy because I can get going, but you have to understand that sickle cell disease still affects patients differently. So we really have to have someone with a relationship with that patient and an understanding of their clinical trajectory leading up to pregnancy. So that level of knowledge, I think, knowing the patient, understanding their clinical status is just as important, if not more important, than giving guidelines or frameworks to take care of these patients. So number one, I would say the relationship has to be there. You have to know about that patient's overall history as far as their baseline laboratory values, the escalation and frequency of their pain crises, and ultimately things and maneuvers that have been done to care for them. Once that has been put in place, a team that understands the importance of the distinctions that sickle cell disease places on patients who are expecting with sickle cell disease versus those who are expectant without the condition. So those two knowledge pieces is where I'll pause now, I think are most important in delivering the most appropriate and conscientious care for this cohort of patients with sickle cell disease.
Great. There's some comments happening in the chat about this. I want to try to put a few things together here. You know, sickle cell disease is a rare disease. And as Dr. Donaldson says, it affects people differently. And the high quality care is individualized. This is an unusual disease, and that's why we need experts who really understand it and its idiosyncrasies. And also this care is really wraparound care. And so when I imagine recreating care that is highly effective for my young people with sickle cell disease, that reproductive health care comes to them in the clinic. So I don't need to be doing the contraception counseling. I don't need to be doing the genetic counselors, but I need those partners with me in the sickle cell center. And we know that when this care is delivered at sickle cell centers, as Dr. Donaldson says, the trust that it comes from those relationships is really, really essential. And what we see, because at Johns Hopkins, we are able to integrate psychiatric care into our sickle cell care model, what we see is that we benefit from learning deeply about psychiatric principles from our psychiatrists, and they learn from us about sickle cell disease. And it really strengthens the kind of care that we can provide because, as we say, sickle cell touches everything. Now, another piece of this is that there is enormous emphasis at the moment on transitions, healthcare transitions, which describes the movement of young people from their pediatric medical home to their adult medical home. And I now care for young adults on the adult side, but before that, some of you know I was a pediatrician and a pediatric hematologist. And what we see is that the resources for that healthcare transition are are inadequate in both settings, but are tremendously weighted towards the pediatric setting. And so what you have is a ramp where you're leading young people who are all approaching reproductive age, who are all having sex or thinking about having sex, because that's what teenagers do, right? And they're walking up this ramp with their pediatric care teams that are in the process or have already developed amazing transition programs. And then they fall off a cliff. And the reason they fall off the cliff is because, first of all, the adult care model is completely different than the pediatric care model. And so it's like they've been walking up a hill learning to read Mandarin. And when they get to the end of the hill, right, like suddenly they can't read Mandarin and everybody is speaking Mandarin and everybody wonders what has happened, right? This is not mysterious what has happened. It's a totally different care system. And so thinking about young adults as actually emerging adults, as people who were children just 2 days ago and are now adults, right? Thinking about them developmentally, the adult care system needs to think developmentally. The adult system needs resources to integrate young adults into adult care, which is actually the final step of transition. And there are really insufficient resources in the healthcare transition on the adult side to integrate young adults into adult care. And part of that care is essentially reproductive care. These are young people who are thinking about their reproductive futures. They're thinking about what their family will look like in the future. Even if they walk into my clinic not ready to have a kid tomorrow, and most of them don't, they are thinking about what that future looks like. They are wondering about whether they are fertile. They are wondering about whether their partner is going to need testing for trait, or if their partner has trait, what would that mean? Some of them have profound misconceptions about how sickle cell is inherited and think that they will pass the disease to their children. So just enormous opportunity for intervention, particularly at this crux moment when people transition into adult care.
Great, thank you all. The next question is from Ms. Ahmed. So Ms. Ahmed, I gotta say, or the first question is, what do you consider to be the biggest barrier for people living with sickle cell disease to receiving high quality care?
So I don't know if there's just one big barrier. There are several. I think one of those is actually listening to patients. So I think the question that was just asked, that was great that we got providers to be able to say, but the same question could be asked to me as a patient. What are the best things, you know, as you're going through reproductive health and talking about becoming pregnant, what's the best types of care, right? So many of the services that are being offered now that Dr. Pecker has been able to add on with other teams over the years were not a part of comprehensive services when I had my daughter. And I like to believe that it was because of conversations that began years ago that things began to increase and get better. So I think listening, having open dialogue and conversations is one of the main things that's really, really important. And then what was the other part of your question?
Well, just sort of the barrier that you think that patients are,
right.
I think you.
So the listening part is a barrier, and that's not just in sickle cell, but has been traditionally how medical and doctors are seen and how the profession has evolved. Really having patients as a part of their own advocacy team or as partners is really a relatively new thing, I would say. I would say also other barriers are socioeconomic barriers for sure. That affect African-American populations as a whole, and then sickle cell patients even more, because even if you have had educational opportunities and may even come from a middle-class family or above, as you begin to go out into life and do your own careers and go to school, and you still have to deal with working with a chronic illness. So you're not on your parents' insurance anymore, you're developing your own. And if you can't stay employed for a while, then you don't have insurance. So definitely insurance and that economic situation is very difficult. And that becomes a barrier there to healthcare. And then opportunities for other types of work and employment and income earning for people with sickle cell disease is also another a barrier, which of course goes back to the money. And then I would say in populations outside of urban areas, depending on where you live in rural areas, then you also have barriers of transportation, having knowledgeable people in your area on staff that know what's going on. That is also can become a barrier, is provider knowledge. So provider knowledge, provider training, and cultural sensitivity training should be a part of that. That is also a barrier.
Great, thank you. Thank you. So the next question that we have is regarding the Medicaid demonstration bill. The questioner would like to understand how the bill can support states, particularly some such as Tennessee, which have a relatively high sickle cell prevalence, but where Medicaid expansion is not available.
I think that's a wonderful question. If I can indulge one of our policy experts, Ms. Riker, to perhaps speak on those scenarios.
Sure, and the key for a state to participate in the demonstration is, I believe, a willingness to work not just with the Department of Health, but also with academic centers within the state. I think most of you on the line know Medicaid programs are under a lot of pressure these days, and they're really strapped. And we're finding both in the CDC surveillance program, sometimes the state is not the grantee, but an academic center is, and the academic center is able to coordinate the work of the state in an activity like data collection. We think part of the planning grants could happen in this kind of a partnership, and we hope that happens. The question is, the questioner clearly understands it's more difficult to do it in a state that hasn't expanded Medicaid, but Tennessee is another high incidence state, so it would get some preference. And our hope is that through partnerships with hematologists, academicians, and community-based organizations. Our community has such strong community-based organizations that can really help with comprehensive care, that these demonstrations can get created. So if you get pushback on a state level as this moves forward, I think beginning to show where partnerships could occur to make it happen would be an effective way to address it.
Great. And the next question here also kind of ties in with the Medicaid demonstration bill as well. I think a lot of our attendees here are not necessarily working on the Hill every day, but they'd like to know how they can still support this legislation even outside of Capitol Hill. So tee that one up for anybody here.
I am happy, Ellen Riker again. I am a policy consultant to ASH and have worked with the team on our policy issues, including the Medicaid bill. ASH, as you know, engages in coalition and tries to spread the word as much as possible. We will do that on this bill as well. As we get closer to introduction, the staffers that were on the briefing today, I think we'll need your support and help to get co-sponsors. The more we can show support for this broadly, I think the more it has a chance of moving forward. I think the other thing I would like to say is I am so pleased that this issue, as most sickle cell issues that we've been working on this year, have been supported in a bipartisan fashion. It's not seen a lot these days, but it is when it comes to sickle cell. So we continue to appreciate bipartisan support and will keep the community apprised. We were so pleased so many organizations co-sponsored our briefing today, and hope we can become a part of our campaign to get the bill in. Thanks.
Dr. Pecker, this next question is for you. Question asks about what do you see as sort of like the very first steps that are needed to improve healthcare and prevent deaths for pregnant women with SCD currently, that you can sort of see as like the beginning of stages here?
Well, the first step is that all adults and children with sickle cell disease need someone who's trained with expertise in sickle cell disease providing their care. And that is a first and necessary step. The second and necessary partner in ensuring safe passage through pregnancy for women with sickle cell disease is having an experienced high-risk obstetric team to care for them. And, you know, young people can gain experience. So I don't want to overemphasize this experience thing. What we need is people who are interested and invested in understanding and carefully treating our patients, and who will work in partnership with us. I think those two things, you know, they've been demonstrated in very different resourced care environments to affect outcomes. So this has been proven in Nigeria to work. When you put obstetricians together with hematologists, you can really transform outcomes for pregnant women with sickle cell disease. And so I think that's probably the floor. You know, this isn't about raising the roof. This is about building the floor. That's the floor for care.
Thank you. Ms. Ahmed, so I'd like to ask, over your lifetime, how has treatment for sickle cell disease changed as you've seen it? Has it improved in any way that you can, in your opinion?
So I think that provider sensitivity and education and believing patients has improved over the years. There's been an improvement in the field of the number of people that providers that want to be hematologists that care for this population. It's not an easy population to care for, and it's not glamorous, and it's also very unpredictable. So although there are not as many providers as we'd like to see interested, the growing number seems to be very dedicated from what I can see. And so that I think has been a good thing and has improved. I think that what has not improved over my lifetime, I will be 50 next year, is the types of major ways in which my crises are treated, the number of medications that have been developed, and then the study and research on life expectancy has not changed greatly. As a child reading, it was 19 or 20. And so that's a terrible thing to read as a 7-8-year-old. Oh my gosh, I'm gonna be 20. And so I had a really good time in high school. And then when I went to college and then turned 20, it was like, I think that book was lying to me. Seeing that the age expectancy did change, but has not changed largely since then. So around 39 to 40. And I'm seeing people that are living, myself and friends of mine that are living past that. So research in those areas and research with medications, I think, will be some areas that can be improved. Although within the last couple years, there have been some added medication. So those things have changed a bit. And then the things that hasn't changed is just the basic way in which a crisis is treated. I would like to see more medications and more research to help change that, because I'm still being treated for a major crisis the same way I was at 18, the same way I was at 20, the same way I was when I was pregnant. So go to the hospital, get IV medicine, and take opioid painkillers.
Thank you. I think we have one more question, time for one more question here, which is, this is sort of a numbers question on how many patients are treated with bone marrow transplant, and this proportion of patients increasing or not. And I'll direct that to Dr. Pecker or Dr. Donald, either one of you.
I don't know a precise statistic. Do you, Dr. Donald? I will say this, the American Society of Hematology just published their transplant guidelines, which make much more clear, especially for children, who should be evaluated for bone marrow transplant, particularly children with sickle cell anemia under the age of 13. And so whatever the number is right now, we should expect it to go up, because while up until those guidelines were released, some amount of these referrals is about equivocation on the part of providers. We now have a line in the sand for about 70% of children with sickle cell anemia that they should be evaluated at least for bone marrow transplant. Dr. Donald, how do you think about that?
I agree with you, but under the banner of this call, the majority of persons do not receive
Right.
hematopoietic stem cell transplantation. It just does not happen. Secondly, challenges of becoming a candidate for it, but then finding a donor through the National Donor Program. So if we're talking about if someone were white, they have about a 70% chance of finding match through that program. Our Black citizens, about 25%. Our Latinx citizens, about 33, 35%. So fraught with challenges, and no, that is not the majority of persons in our country. The vast minority receive hematopoietic stem cell transplantation.
I believe about 10% of children with sickle cell anemia have a matched sibling donor, just to put that in perspective.
Wow.
I think we are right at time, so I'll end the Q&A session. I'm sorry if we did not get to everyone's questions this time, but we do appreciate everyone for attending today's session, and I'll let anyone like to say final words.
I'm happy to give the final word to Ms. Ahmed, but I'm happy to go, and then I can hand it over to Dr. Pecker. I just want to ask for everyone on this call to realize that persons living with sickle cell disease are at every level of our society, and they contribute to this society. They're part of our military, they teach our children, they help us in hospitals, they keep us safe. So this bill will help us better take care of our citizens that are suffering from a condition and a disease that just has not received the level of research funding, has not received the level of innovation as other diseases, and then unfortunately places our patients in a system with systemic issues of racism and bias. This is all very real. We have to be honest about solving this problem, and this demonstration bill is a step towards that answer. And I thank you for your time today.
Thanks, Dr. Donald. You speak for me. Ms. Ahmed?
I was going to say the same thing. I would just like to add to that because we are everywhere, when I started advocacy and working with transition programs, my main goal was about education and awareness. Too often when people hear about sickle cell, I call it the I've heard of it disease. People have heard of it, but know very little about it, very little detailed information about it. But chances are you've gone to school with someone, you have, particularly if you live in urban areas, but even not in largely urban areas anymore, you've gone to school with someone, you've worked with someone who either they or their child or a cousin or a relative, you're within 2 degrees of a 1 to 2 degrees separation of someone who has sickle cell disease. And so if we think about it like that, you are encountering every day, and that we need to definitely have more education and awareness, because when we have that helps people to understand why this type of legislation is important, and why sickle cell programs that currently exist are important, and why they need to be expanded.
Very well said. Thank you so much. Great wrap up there. Have a great rest of your day, and thank you for attending.
Thank you. Thank you, everyone.
Should we drop off? Yes? Okay.